So hello everyone, I'm Fiona Mendes, an emergency medicine doctor with a subspecialty in pediatric emergency medicine. Thank you for the opportunity to present today. This case presentation was encountered earlier this year when working in the pediatric emergency department at Whipps Cross University Hospital, based in East London. A 15-year-old male presented to our pediatric emergency department with vomiting and generalized abdominal pain. His mother also worked at the hospital. He had reduced eating and drinking due to nausea. He had no fevers or diarrhea. He was passing urine, but this was reduced in volume and frequency, and he had no other urinary symptoms. There was no reason for travel, and no other contacts were unwell. He had initially told us that he didn't use any recreational drugs or alcohol, but he smoked occasionally, and he had been previously well. His mother was concerned that he was missing some school due to his symptoms, which were similar as this presentation, and they would occur every few months, but usually ease after resting at home. On examination, he was very anxious, appeared unwell, and was clinically dry with a resting tachycardia. Of note, his abdomen had superficial erythema from using hot water bottles. His abdomen was soft with mild generalized tenderness, and this was variable on re-examination. So initially, he was treated for viral gastroenteritis. Our differential diagnosis included an early acute appendicitis or mesenteric adenitis, but these seemed less likely. On review, however, he didn't tolerate his oral fluid challenge. Blood test showed an acute kidney injury, a raised lactate of 6, hypoglycemia, and hypokalemia. His ECG had a sinus tachycardia. His urine analysis shows raised ketones in keeping with his dehydration. He was admitted to the children's ward for further management, and he had an abdominal ultrasound which showed no abnormality. He required intravenous fluids and intravenous ondansetron. His electrolyte abnormalities were corrected. His hypoglycemia was corrected with oral glucose and hydration, and his tachycardia settled with rehydration. As his nausea and vomiting eased, he was able to tolerate oral fluids and food, and his urine output was measured and increased. However, his pain was still poorly controlled with paracetamol, ibuprofen, and codeine. When his mother was called away, the pediatric team took this opportunity to perform a HEEADSSS assessment, which is a psychosocial assessment assessing the physical, emotional, and social well-being of adolescents to create this holistic picture using structured questions. And it was then that he disclosed his long-term cannabis use. His use had gradually increased during the pandemic, lockdowns, to manage stress related to school, and he was very reluctant to disclose this in front of his mother. He had grave concerns that he would be in trouble, or that his mother would be in trouble with the law because he had hidden cannabis in his bedroom, or that she could lose her job at the hospital, and so he didn't want his parents to know about this, although it was later revealed that they had suspected that he was smoking cannabis. Cannabis would initially ease his nausea, and so he increased his smoking of cannabis every 2 to 3 days, and then he would develop this persistent vomiting, and where he was concerned that he would no longer be able to smoke cannabis. After a few days, the symptoms would then ease. He discovered unintentionally that using hot water bottles and hot showers could help ease some of his symptoms. So he was managed for suspected cannabinoid hyperemesis syndrome. This involves cyclical nausea, vomiting, and abdominal pain associated with prolonged cannabis use. Cannabinoids are compounds derived from the cannabis plant or as synthetic compounds. The pathophysiology of this diagnosis is unclear, but research has suggested several mechanisms. So for this case, Talkspace was consulted. His creatine kinase levels were checked retrospectively, and they were slightly raised, which were corrected with IV fluids. He had 2 separate urine toxicology screens performed, and they both were positive only for cannabinoids. His acute symptoms were managed with topical capsaicin cream, ondansetron, and oral rehydration, and his acute symptoms settled after he stopped using cannabis. He required a lot of support to understand the link between his cannabis use and the symptoms, and to discuss this with his mother, and he continues receiving support in the community for the psychosocial aspects of his care. Recent conferences from the Royal College of Emergency Medicine over the past few years have highlighted that cannabis use and the prevalence of cannabinoid hyperemesis syndrome have increased, associated with increased cannabis use during lockdown. During the pandemic lockdowns, there was increased online purchases of grow your own cannabis from seeds, for home cultivation to ensure that there was a consistent supply of cannabis. There were lots of online resources and popular TV shows showing cooking with cannabis. And this may have led to adolescents to form the misconception that cannabis is harmless. During the lockdowns, party drugs or nightclub recreational drugs such as amphetamine, ecstasy, or MDMA, those drugs reduced, but the cannabis recreational drugs increased. And this was in keeping with the slogan of keep calm, stay at home, and smoke weed. So cannabinoid hyperemesis syndrome is a clinical diagnosis after excluding the medical and surgical pathological emergencies. The diagnosis requires a prolonged cannabis use history, and there are no specific investigations to confirm this diagnosis. However, this table shows the common characteristics of cannabinoid hyperemesis syndrome and the frequency in which they occur. It's important to note that it's unlikely that the definitive diagnosis of cannabinoid hyperemesis syndrome will be made in the acute setting or in the emergency department because of the diagnostic criteria required. However, having an awareness can help clinicians support and manage patients that present with these classical features. And they may unintentionally discover that hot baths and showers relieve some of their symptoms. The literature describes three phases of cannabinoid hyperemesis syndrome. The first is the prodromal or pre-emetic phase, where patients have nausea and mild abdominal pain. And they may believe that if they increase their cannabis use in this stage, because of its antiemetic properties, it will stop the symptoms. However, with increased use, this then pushes them into the hyperemetic phase. And this is when they're most likely to present to the emergency department or seek medical opinion. Because they will have severe nausea and vomiting and severe abdominal pain, and they may have some of the complications which are serious and fatal, such as dehydration, acute kidney injury or renal failure, electrolyte abnormalities, or hypoglycemia. And then if they're too unwell to continue smoking cannabis, their symptoms may subside as they enter the recovery phase and with treatment. When they enter the recovery phase, they may then feel that they are better enough to smoke cannabis again or use cannabinoid-containing products, and then that pushes them back into the hyperemetic phase. So the most effective treatment is stopping cannabis completely to break that cycle. But because of this paradox of with cannabis having antiemetic properties, it's difficult for patients to make that connection that their symptoms are related to their cannabis use. It's also difficult for them to stop completely without psychosocial support and community-based support because they need to address the underlying reasons that's causing them to use cannabis as well. So in the immediate management in the acute setting is usually rehydration, either with oral fluids first and then intravenous fluids if required, and antiemetics. If traditional antiemetics don't work, then it's recommended to try intramuscular haloperidol. And capsaicin cream, which contains a derivative from chili peppers, ideally the 0.1% solution, applied topically to the abdomen can help alleviate some of their symptoms. The Royal College of Emergency Medicine released recent guidelines on this, and it recognizes that it's an emerging and challenging diagnosis, and and as cannabis use increases, particularly in younger people, this is an emerging diagnosis too. It's important to encourage disclosure though, and adolescents in particular may be really fearful of the legal consequences or getting into trouble. So in the emergency department, it's important to create a safe space and encourage them to disclose their cannabis use. So the key learning points from this case were the teachable moments, recognizing that there's a connection between, for patients to make the connection between their cannabis use and their symptoms before any preventative measures can be instigated. The HEEADSSS assessment in this case helped us uncover the diagnosis. Without this diagnosis could have easily been missed. And then patient-centered care, so thinking about alternative diagnoses and other treatment options when the presentation doesn't fit the diagnosis already made. These are my references, and I'd like to acknowledge the patient and their mother who were really keen to share this case, which we're grateful for. And I welcome any questions or comments. Thank you.
So my name is Motaz. I'm one of the pediatric registrars working at Addenbrook's PICU. I'm gonna take the following 10 minutes to present an interesting case for a child who's been struck by lightning. So I'm gonna try to, in the next 10 minutes, to try to raise the awareness of lightning strikes injury, and obviously try to give you a little bit of insight into how to assess cases in ED, and highlight some of the common injuries from lightning strikes. So I'm gonna start with a sort of a pre-alert of a 13-year-old who was struck by lightning on a playfield. He stopped breathing, but received a bystander CPR straight away. Had an EED put on by the people around him and got one shock. So air ambulance was notified and attended straight away around 20 minutes of the incident. He was intubated on scene, received 1 dose of adrenaline, and received magnesium and calcium corrections. He had ROSC estimated around 30 minutes from the initial alert, and en route he was noted to be arrhythmogenic but had a stable blood pressure, cautious of stable. So you being an ED, on your initial assessment, so he's intubated on scene. He had a reduced air entry on the basis with brown aspirates from the ET tube. He had a very weak pedal pulses. GCS was 3 out of 15. Obviously, he was sedated. He had extensive bruising noted, mostly on the lower limbs. His initial observations, he had a temperature of 35.5 with a heart rate of 135 and blood pressure of 144 over 104 with a MAPS of 121 with rest rates of 16 and FiO2 of 60%. So on the bedside, your initial investigations would be getting a blood gas, I hope so. So a pH, so the blood gas had a pH of 7.1 and a CO2 of 6 with a good going base excess of -12 and a bicarb of 16.3, lactate of 2.5. And that was his ECG. I'm keeping my eye on the YouTube comments as well. Can you define one abnormality? Just one. Yes, we've got T inversion and a biphasic, yes. So we can see a sort of premature ventricular ectopics here. Sort of a triple try ones and 2 sort of premature ventricular beats here as well. And there is lots of yes, we've got an ST elevation in V2 and V3, perfect. You can appreciate there is some interference on this ECG. There is another one as well. This more obvious. So we've got a, obviously if you look at the inferior leads and you've got an STV elevation, lead 2, lead 3, you've got an AVF, and you've got on V4, V5, V6, and V3 as well. So his initial bloods, full blood count was unremarkable, but you can see on his chemistry profile and cardiac profile, he's got a CK of 10,000, a rising 1, and his initial troponins were more than the lab reference. I think the lab limits were above 25K. So what's happening? So with lightning strikes, you get a difference in the electrical potential between the clouds and the ground, and it's usually more than 30,000 volts. This generates a very good going currents that vary up to 100K, 100,000 amperes. And it is estimated that you've got 44 flashes that occur per second and 1.4 billion flashes in a year. 24,000 people are thought to die from lightning-related injuries. So you can probably tell how lucky or unlucky you are if you are on call on that day. So the basic understanding is you've got an extremely high voltage on a very short and extremely short duration, around 10 to 100 milliseconds. And if there is one takeaway to take away from this presentation is the electricity travels through the path of least resistance. So you've got nerves, then bloods, then muscle, then skin, then fat, then bone. And it helps you sort of decide what you will be looking for in a patient who's presenting in such presentation. So the one that you see in the movies where the lightning strike hits the head, that's very rare. So this is what we call a direct strike. 50% of the children who's having lightning strikes, what happens is the lightning will travel through the ground and then to the victim, and then will strike on one of their feet. Obviously, we've got a side splash and contact injury. So contact injury would be if you essentially in direct contact with whatever object that got hit by lightning strike. And a side splash is essentially where you the current jumps to the victim, but not in physical contact. So taking the previous slide, so you will have a cardiorespiratory arrest. You can have a cardiorespiratory arrest. You can have all different types of arrhythmias, including asystole, VF. You've got lots of ST elevations and QT prolongation. You will have an ARDS, an aspiration from a respiratory point of view. And you, from a neurological point of view, you can get immediate and delayed sort of insults. So cranoparalysis is which it's a condition that would mimic the spinal cord injury, where because of vasospasm you've got a motor and sensory changes, which can cause cyanosis, pallor, and pulselessness, and it's mostly on the lower limbs compared to the upper limbs. But this tends to sort of resolve after some duration. But obviously you can get some things which are permanent, like an HIE and a progressive myelopathy as well. You can get cataracts as well. You can get optic nerve injury. Tympanic membrane rupture mostly resolves spontaneously with conservative management. Otorrhea, you can also suspect skull base fractures, and you can get permanent hearing loss. There is also a very famous Lichtenberg figures. I'm not sure if you've seen them, which is like a sort of a transient feathering patterns, which you get from a lightning strike, and full thickness contact burns and punctate burns. So you can see how the pattern of the bruises that can take shape on the lower limbs. So it's really important to highlight the cardiac effects when you get a lightning strike, and it's mainly to point on the vasospasm and vascular injury, for which it causes myocardial ischemia and infarction, as well as can potentiate to a sort of ventricular failure and myocardial stunning. But at the same time, you get the catecholamine surge as well because of the strike, which gives you more arrhythmias and also predisposes to myocardial stunning. So for our patient, he had an echo which on day one which showed severe impaired systolic function. He was started on melrinone, and that choice was mainly because of the function of the melrinone in sort of improving the inotropy, improving the heart contractility, at the same time giving a little bit of vasodilatation by relaxing the smooth muscles in the blood vessels. He was planned to have a cardiac MRI once he got into a stable position, and close monitoring of renal function to consider him to have any sort of filtration. He did have a repeat echo on day 3, which showed slightly improved function. On day 4, his paralysis was stopped and his feeds were started, and melrinone was titrated. And on day 5, he was stopped, melrinone was stopped, and sedation was stopped. He was extubated into air on day 6 from his presentation, and he was discharged from PICU for rehabilitation on day 8. He had a further serial ECGs. So on day 3, he had a slightly improved ECG in terms of the less sort of ectopics, but he still had some element of ST elevation. This was his ECG on day 5, which also continued to improve. And his chemistry before discharging from PICU showed that troponin came down to 5,500. He was discharged home 6 weeks after being stepped down. He did have some oral captopril for the management of his hypertension. He did regain his cognitive function and neurological status, and it was on an improving trajectory. And he used to play football, and he's now back to playing football again, which was really encouraging as well. Obviously, he's having continued neurology and cardiology follow-up. Thank you. I hope I didn't cross my 10 minutes.
Yeah, so please vote which of the 2 fabulous presentations you like the most. The winner gets a prize. Okay, we've got 51 votes. I think lightning strike edges it.